said that, we are going to move to the first roundtable this morning, and we're going to talk about the user experience for HIV self-testing, the possibility for incorporating other types of self-test. Segundo Leon, who is a member of the board of Alandiv and a professor from the San Juan Bautista University in Peru, will be moderating this session. Good morning and welcome to the second day and the second part of such an intense day. As mentioned by Carlos, we continue to talk about tests, and we will talk about self-tests for HIV and the experience of Brazil, because definitely what was done about HIV in Brazil and in other countries to incorporate other self-tests can be useful. We have a very interesting discussion with Mariana Milhares from the Ministry of Health, Alison from the Ministry of Health of Brazil, Ana Paula Moreira, Carlos Solidan from the University of São Paulo, Mariana Vilares. Good morning and welcome.
Olá, pessoal, bom dia. Vocês confirmam que estão me escutando?
Good morning, everyone. Can you hear me well?
Obrigada.
Okay, perfect. So good morning, everyone. It's a pleasure to be here. I have watched the talks yesterday, and I think some of the information I'm going to present is going to contribute. My name is Mariana Vilares. I work at the Ministry of Health at the HIV diagnostics and hepatitis and other STDs department. So today I'm going to present how the self-testing of HIV is working in Brazil.
E agora vocês conseguem ver no modo já de apresentação?
Please confirm if you can see my presentation in the presentation mode. Okay, perfect, thank you. So José talked a little bit about this yesterday. So just to give you a little bit of context, this is our cascade. So we are focusing on the improvement of our status. So we have 88% of people diagnosed in 2020, and this increase is due to the rapid test that was implemented in 2012, and therefore there was this acceleration. The closer we are to 90, 95, and 100%, the more difficult it is to actually get to those people who are missing. So what is our challenge? To reach that population that was not reached yet. So José has presented this yesterday, but this is the data of prevalence in Brazil. So in the general population, we see 0.4%, but in gays and men who have sex with other men, 18%, women sex workers 5%, and trans women 16.9%. We also have a very young population that needs to be in focus. Since this is a concentrated epidemic, we need focus, and the most vulnerable population that have less access to healthcare services are those people that need to be reached. Therefore, we started to work with the HIV self-testing since 2018. Our strategy to distribute the auto tests is to reach people that are not diagnosed. The focus are key populations and priority populations who do not have access to healthcare services. And the main strategies are the distribution of tests outside healthcare service and the secondary distribution through partnerships. So on the right side, it's an illustration of from the black dot getting to the other secondary distributions. We have three strategies for distribution. The first one is to deliver self-tests to PrEP users so that they can deliver it to sexual partners. People using PrEP are people who understand HIV, know that they are at risk. There are criteria for people eligible for PrEP use, and they have contact with people who could benefit from this technology. So they could get at each appointment 5 tests delivered to sexual partners. Our second strategy is to distribute tests in sociability locations, which can be done through healthcare professionals. And this strategy can deliver self-tests to people who are approached and other 5 tests to sexual partners. Another strategy is to deliver the test to people coming to healthcare services who are during an appointment or doing a test, and they can receive other 5 self-tests to deliver to other people. We have one guideline document that is available on our website. There you have the details of our strategy if you want to find out more. We have 15 minutes only, so that you can find additional information there. On our website, we have a page dedicated to HIV self-tests. So you can find the information about how it works in the public healthcare system, additional information, how to perform the self-test, how to interpret the result. You can also find where you can get a self-test for free. There is a frequent question session, also information materials, and these are some examples of what you can find on our website. So you have a brochure, you have a poster that you could place at locations for distribution. We have short demo videos. We have 2 videos. We started the strategy with one blood self-test, and now we use the oral fluid on a self-test as well. We also have a video talking about the auto test and how it works, another brochure, and the interactive panel where you can find additional information. Since 2018, we have been conducting monitoring to help in decision-making and adjust the strategy if necessary, and also to update the public policies. How do we do that monitoring? For people living with HIV who go to an appointment, they make a registration when they get an auto test. And for people who do not have a follow-up at the public healthcare service, they fill up an anonymous form with social demographic information about sexuality. So to talk a little bit about the results, this is probably our main slide in our presentation. We started with a pilot program in 14 cities in December of 2018 with the use of blood auto test, the action test. This data is up to September 2021. So you can see that this is the number of self-tests distributed per month. So we started the pilot program in December 2018. We conducted a workshop with regional coordinations and representatives of some strategies and NGOs in July 2019. So you see an increase of number of tests distributed after the workshop. So we've expanded a little bit the population. In January 2020, we've enlarged the program for the whole country. So up from January, the whole country could distribute self-tests. In March, we had the beginning of the pandemic, so we've seen a small reduction of the number of tests distributed. And then we released a note about recommendations on social distance to talk about the importance of self-testing. We started to recommend the use of auto tests so that people could substitute the rapid tests by self-tests so that key populations could be reached. So in April, we published those recommendations and we conducted a few webinars to talk about that document and answer questions. And then in May and June, we can see a quick increase in the auto test distribution. We ended up clearing our stock, and we had already a purchase with the Ministry of Health going on. So by the end of November, our stock was depleted, but we still had some local stocks, and so the distribution did not stop. In April this year, we started distributing a new test in the public healthcare system, which is the HIV Detect that uses the anaural fluid sample. So this test was approved by Anvisa regarding its technical features, and it presented the lowest cost. So we started seeing again an increase on the distribution of the self-test. Here at the bottom, you can see the strategies. So this is the individual distribution, the distribution for PrEP users, distribution for HIV and PV to bring over to partners, the consolidated distribution, which is when we do not have individual forms, so we leave a certain amount of tests in locations where people go to, and the total of 344,209 tests distributed up to September. This is a chart showing the number of cities distributing self-tests. In blue is the number of cities distributing tests during that month. So you can see that with the decrease in stock, there's a decrease in the number of cities. In red are the new cities, and the green line shows the accumulated number of cities. So up to October, we had 239 cities in Brazil distributing the auto test. We will have data from November published on December 10th. So what are we able to reach? What is the result of our work? Here on the left-hand side, you see the mean number of auto tests. So it varies depending on the strategy, but on average, people get 3 auto tests each. Here below in the dots, you see information regarding the age of people who get auto tests. So Jose talked yesterday about the young population getting infected by HIV. So we have to reach that population. It's a type of people that do not go to the healthcare services. So 20% of people getting auto tests. This is data from people who went there to pick up tests, not necessarily the data about people who conducted tests. So 20% were between 18 and 24, and 21% between 25 and 29 years. So 41% of the people were between 18 and 29 years. Regarding the last test for HIV, 20% had never done an HIV test, which shows that we are getting to a population that we did not approach before. If we see the age between 18 and 24, this percentage goes up to 27%. So we are approaching a population that is much younger and that does not do any tests. Regarding gender identity, we see that the largest population reached with this strategy are gay men and men who have sex with other men, then cis women. And what we also believe it's interesting, it's this 5% here of trans people. We would like that number to be higher, but we already believe that 5% is already good because we are reaching those people a lot more than the traditional healthcare services. Regarding race and color, 51% is white and yellow, 48% Black people, 1% indigenous people, and 2% ignored. Regarding our interactive panel, you can find all the information from those two last slides on that website. So here's the hyperlink to find all that information there. And there you can see all the information regarding the HIV test, and you can filter the information. So here is the first page. You can filter by state, for example, and then you can get separated data by state. And without filtering, this is the information on the panel. So you see there are 4 of 7 pages there, and this is the filter regarding Brazil. But if you want to select, for example, other state, you can do that and you can check the information about that particular state. You can also select by individual distribution or through the PEP strategy, and there's a lot of information that's very interesting for you there. That would be it. Thank you so much, and I'm available for any questions later on. Thank you.
Thank you, Mariana. That was very interesting. 350,000 tests or self-tests distributed, and a high percentage of people between 18 and 24. This is really interesting. The data that you shared are really an example that many countries need to follow. We have some questions for you, Mariana, so please stay with us. Now, I would like to invite the representative from the Ministry of Health that will talk a little bit about decentralization of diagnosis. Alison, good morning and welcome. Good morning, everyone. I'm going to share my screen, and please let me know when it is working. Can you see my screen? It's perfect. Actually, we can hear you, but not see the presentation. Well, first, I would like to thank you for the invitation for coming to this event. All the discussions since yesterday have been really fruitful. I have some data from Brazil, and part of this presentation is an invitation for us to think as a group in which areas we can advance in regarding diagnosis, especially in providing autonomy to users and different individuals. My name is Alison Bigelin, and I'm part of the diagnosis team for the Department of Chronic Diseases and Sexually Transmitted Diseases or Infections. We have been talking about this decentralized model. An initial model that we have is based in lab tests. And in this case, we need people to leave their homes and go to one health care center for an appointment, and later either that person or the person's sample is sent to the lab, and that person then returns home and wait for the test to be conducted, and later he needs to collect the results. So there is a whole journey that this person needs to go through in the healthcare service. But if we think about more specific situations, if we look closer at some people, they can be living in high vulnerability situations, which make it impossible for them to fulfill this journey inside the healthcare system. Many times they use their financial resources for other purposes instead of for paying, for example, for transportation to go to the healthcare facility. A model that is based on rapid tests, individuals, they go to the health center and they have access to the diagnosis right there. But even in this model, we still need the support from the lab for some specific situations. But if we look at some groups of people, for example, sex workers or trans people, some of these people don't choose this model due to the stigma that is associated to them. And then we have a third model that was presented by Mariana, which is a self-test model. Individuals that test negative in this model, they already have an answer and do not need to go to a healthcare center. However, if they test positive, they do need to go to a healthcare center to conduct complementary tests with the support of a lab. So this is the possibility that we have for decentralizing diagnosis. Another way to approach this is when diagnoses are centered in the healthcare center, several different individuals will need to access the same health care center that, especially in Brazil, are overcrowded. We often hear about how crowded these services are. So this only highlights the need for decentralizing this service. When we think about a model that focuses on the autonomy of different people, only those who truly need to continue their treatment will go to these healthcare centers, and that will bring more agility to the whole system and an ability to focus on those people who truly need to be seen in the healthcare center. We have been working on the use of rapid tests for a very long time in Brazil, and I would like to highlight some moments during this journey, especially regarding rapid tests. So in 2001, we started to see in the recommendations for the prophylaxis of the mother-child transmission of HIV, the recommendation of using rapid tests for some specific emergency situations. In 2007, in the first clinical protocol to prevent the vertical transmission of HIV and syphilis, the rapid tests were presented as an alternative for diagnosing syphilis. Later, in 2012, the Ministry of Health included rapid tests in the basic healthcare level for the detection of HIV and syphilis, which allowed us to decentralize the model. So here are some strategies that we use in Brazil. Like I said before, the rapid test in the primary care services. We also have some projects that are conducted by civil society associations that they do a screening testing strategy. And this project between 2018 and 2019 demonstrated that 1.4% of people had a positive test for HIV, and 47% of those people had never been tested before. And as mentioned by Mariana, we also have the distribution of self-tests for HIV in the country. Now, some data about the decentralization model we have. We can see that since 2012, there has been an increase in the number of tests distributed by the Ministry of Health, with a slight drop in 2019 and 2020, probably the result of the pandemic, but with a slight increase in 2021. This is data that goes up to September this year. In 2020, 2019, the Ministry of Health performed a great acquisition of rapid tests, and we can see that HIV rapid tests are already present in 95% of cities in Brazil. They are represented in the green area in the map, showing how this methodology is truly decentralizing the testing in Brazil. But as mentioned by José, it's important to consider the quality of these tests. So at the Ministry of Health, we use some tools to conduct frequent assessment of the tests. We have a tool for remote training for the use of these tests. The National Institute of Quality Assurance conducts an analysis in all the batches that are acquired by the Ministry of Health. We have an external quality assessment program for rapid tests, and we monitor any problems that can come from the use of the tests that are provided by the Ministry of Health. So as seen before, we have this cascade of continuous care and the use of rapid tests from 2012 up until 2020. We were able to see an advancement in the diagnosis of HIV. So these tests have made a great contribution in that sense. And as previously shown, we have a higher prevalence in some population groups, and we need other strategies to reach those population groups. So the Ministry of Health published a quick guideline for focus testing, so we can truly start focusing on the population groups with a higher prevalence of the epidemic. And one of the strategies in the guideline includes the testing of sexual partners of those people living with HIV. Another strategy adopted by the Ministry of Health, later Daniela is going to talk more about this, but we are conducting validation studies, and in the next year we will incorporate rapid tests for the simultaneous detection of HIV and syphilis. So we would be able to detect two diseases in the same test. And this is another strategy to expand diagnosis for both diseases in a single test. Now, if we think about other conditions, the World Health Organization published this year a guideline with recommendations on the use of self-testing for hepatitis C. This test is being approached as an additional approach, and it is recommended by the WHO with a strong recommendation with moderate level evidence. So the guideline mentions that the hepatitis C self-testing it's a convenient option for people that do not usually go to the healthcare centers and that prefer to use self-care in their lives. And the idea is to expand access to different population groups in places with a high prevalence of the disease. The implementation, however, should be focused in priority population groups and regions. There is no direct evidence on the efficacy of the use of hepatitis C self-testing, but all the studies were based on studies regarding the efficiency of HIV self-testing, because this is an experience that exists globally. So regarding our experience with HIV self-test, we know that it increases acceptance to be tested, it increases access. People that use self-tests receive comparable care to those using the traditional healthcare services, and social damages are very rare. So that support us in the new strategy of start using hepatitis C self-testing. Many people show that they want and they're capable of conducting the tests, is acceptable and feasible. It, again, increases access to those who couldn't be tested in any other way. And even though they are more, they allow us to diagnose more cases. So the guideline also presents all the different steps of implementation for hepatitis C self-testing. I would say that Brazil is still at the planning stage, at the first stage. We are reviewing data, identifying the gaps, and what strategy could be used to include this testing in the country. Regarding syphilis, the situation is a little bit more complex because the diagnosis of syphilis is based on the combination of tests, and we know that the non-tryptamic tests, even though we already have some automated testing, some self-testing, they are still very much focused in the laboratory model. And since most people remain positive in their testing, how could we use a self-testing, or how strategic would be to do a self-collection in regions with a high prevalence? WHO has been working in some recommendations for self-care interventions, defining self-care as when individuals, families, and communities can prevent diseases, maintain their health with or without the support of a healthcare professional. So the idea is to decentralize the model and provide more autonomy to individuals. A study from 2015, and now I'm talking about self-sampling, another strategy to decentralize diagnosis. A 2015 study mentioned self-sampling in a quantitative analysis with the use of DBS, and it showed that this model allows for a more private sampling, more accessibility for potential users. It's easier to do the sampling and to transport the samples, and it reduces overall costs for the healthcare providers. And again, it's that idea of providing access to everyone who needs it. This study is a meta-analysis review with the use of self-sampling in comparison to the sampling conducted in healthcare services for chlamydia and gonorrhea. And it shows that sensibility and specificity for vaginal self-sampling for chlamydia and gonorrhea have a pretty satisfactory performance. So it is a strategy of using this type of vaginal self-sampling, and a high sensibility and sensitivity for urine sampling for detecting chlamydia and gonorrhea in men. So we have studies demonstrating how much self-sampling can contribute to the detection of other STDs, such as chlamydia and gonorrhea. This most recent study shows at-home self-sampling, and it basically assessed the acceptability of at-home self-sampling for SARS-CoV-2. And the study showed that more than 84% of individuals reported that collecting, packing, and shipping of saliva, OPS, and DBS specimens were acceptable, and nearly 87% reported being confident on the results that were collected at home.
Another study shows the risks of self-testing. So it's the low return rate of laboratories, the uncertain follow-up. So if people are going to services, the unnecessary use resulting in false positives, the incorrect use or lack of comprehension of the window, and lack of vigilance data. So the study brings all the models that I've mentioned before. We can have a self-testing model or a self-sampling model, and that sample is sent to the laboratory for analysis. So here are the different models. There are benefits and disadvantages of each model, but with all of them, we have a potential for reaching people who need testing and how they might be linked to the care. So maybe the rapid test is the one that creates more linkage because it's already offered during the appointment. This is an example of use of self-testing or self-sampling in the UK. So people are able to go on the website, and based on their age and location, they offer different self-testing models, and the tests are sent by mail for free, and they can do the self-sampling and send back to the laboratory. There are challenges like regarding the orientation of individuals, the validation of the assays for this type of sampling, the validation of logistics, and the return of the results, and how to guarantee that people have a follow-up. This is our last slide talking about the future. We're thinking about using drones to transport samples. Of course, this is a model being tested in Brazil right now and focusing on transporting samples to the laboratory. but we might think about a different approach through telehealth and then sending the tests and the samples by drones then afterwards. So that would be it, my presentation, to think about the self-testing as a decentralization tool. Thank you very much. Thank you very much, Alison. You have showed how it's important to decentralize the rapid tests in Brazil, but also the use of academic references and what the WHO is thinking about it. So thank you very much again.